Very good evening to all of you. And today we shall be discussing a very important topic, which is comprehensive genomic profiling and its implications in clinical oncology practice. Because everybody has started doing this CGP, and CGP has come in the guidelines also. And what are its importance in clinical practice? Next slide, please. Next slide.
Yes.
Now, first of all, our agenda would be to know what is precision medicine and what is precision oncology and comprehensive genomic profiling. And what is comprehensive genomic profiling? We should know this. And when is CGP necessary? How it helps in today's clinical practice? What are the advantages and why CGP is necessary? And where do we stand today? And how to choose a CGP and how CGP helps in different solid cancer types. CGP as a patient-centric tool. So now, next slide. Now we discuss about what is precision medicine. Precision medicine is one of the approaches in clinical practice where the information about individuals' genetic information, that is the blueprint we call it, or protein signature in combination with the clinical signs and symptoms of presentation is used to diagnose, prevent, or treat a disease condition. Now, here I would like to add that in precision medicine, we not only see the clinical picture of the patient, we also see the molecular profile of the patient. That is called precision medicine or personalized medicine. Next. Now, precision oncology and comprehensive genomic profiling. If we see precision oncology is a field of medicine where in the genomic and protein expression of a patient's tumor tissue, along with clinical and pathological presentation, is used for accurate diagnosis and planned treatment with maximum benefits and least side effects. That means we give benefits to the patient, the efficacy of the treatment, and least side effects. And what is comprehensive genomic profiling? It is one of the successful approaches today in clinical practice that has helped oncologists to practice precision medicine in order to derive best treatment outcomes and quality of life for cancer patients. Because not only outcomes are important, the quality of life of cancer patients is also equally important. So, to name a few, I would like to say that HER2 positive breast cancer cells can be targeted with anti-HER2 therapy, which we have trastuzumab and pertuzumab. These are the antibodies to HER2 new, and we have assessment of various gene mutations and fusions. In lung cancer also, we do all a lung cancer profiling where we detect T790M, RAS, RAF, PI3 kinase, mTOR, FGFR mutations and fusions, and MET amplification to understand the mechanism of resistance to TKIs. We are using tyrosine kinase inhibitors for each mutation. And then we also know the mechanism of resistance with MET amplification, and we can use MET inhibitors. And these are EGFR mutation positive. Next slide, please. Now, here we see that genomic alterations are there, and then genomic signatures are there. And here you see base substitutions, then insertions and deletions are there. And then in genomic signatures, we have TMB, tumor mutational burden, and microsatellite instability. And let me tell you that TMB and MSI are important biomarkers for the immunotherapy profiling. Next slide, please. Now, when CGP is necessary and how it helps in today's clinical practice. when a cancer patient is not responding to a standard of care clinical guidelines. Sir, all patients do not respond to a particular treatment. So when a patient doesn't respond and patient has progressive disease, we should understand the biology at the molecular level. And how can we understand biology at the molecular level? We can understand using CGP guidelines. So if we use CGP, we can understand the biological basis and then treat the patient accordingly. Now, non-small cell lung cancer, prostate cancer, pancreatic, metastatic colorectal cancer, triple negative breast cancer, and high-grade serous ovarian carcinoma, CGP of the tumor as well as germline mutations and analysis from a patient's blood is indicated at the time of diagnosis and disease progression to decide the course of treatment planning and options for the future. Now, here I would like to point out that germline mutations, we do it from the blood, and somatic mutations, we do it from the CGP of the tumor tissue. So we do both. For example, in triple negative breast cancer, when a patient comes, then in all the cases, we do a germline mutational analysis of the hereditary genes. Once we do hereditary gene panel, we know which mutations are present if they are present, or there may be no mutation at all. And for somatic mutations, we send the tumor tissue to detect the mutations or amplifications. For rare and complex histology of cancers, there are no specific standard of care guidelines. So CGP would help in treatment planning for both conventional chemo as well as targeted therapy options. Now, malignancies of unknown primary origin, sometimes we get in 20% of the cases, and CGP has a great value in making informed decision for the treatment planning at the baseline as well as during the course of treatment. Next slide, please. Now, advantage why CGP is necessary. Now, here you see on one side we have DNA variants, on the other side we have the signatures. So DNA variants could be single nucleotide variants, it could be insertion and deletion, as I showed you earlier, or it could be copy number variants. And here RNA variants are fusions and splice variants. Then we have TMB, tumor mutational burden, and MSI, which is microsatellite instability. And TNB and MSI, I told you, we have very good drugs, and we also, these are biomarkers for immunotherapy. Now, let me tell you that CGP is highly cost effective as compared to sequential testing. Earlier, what we used to do sequential testing. You do TMB and MSI in one go, and then you do the genomic analysis in another setting. So we are wasting money on this, spending more money, and so in sequential setting, it is not cost effective. It helps in taking informed clinical decision based on molecular spectrum. So we know the molecular spectrum of the patient, and potential to provide clinical trial alternatives to patients when FDA-approved drugs are not an option. So where there are no FDA-approved drugs, we can always go in for clinical trials. And it helps oncologists eliminate futile or potentially harmful treatment based on patient's germline and tumor genetic signature. So it has a pan-cancer coverage. So in one go with CGP, we can get the pan-cancer coverage. Next slide. Now, where do we stand today in precision medicine? It does not include only biomarker-driven targeted therapy, but also of the choice of combining cytotoxic, cytostatic, and anti-angiogenic, and other drug modulations depending on the clinical guidelines provided to us by various, like ASCO guidelines, like ESMO guidelines, All these guidelines are there. And where do we stand today? Now, if we go back to 2000 and 2010, we had single gene sequencing. Then we came to disease-specific hotspot panel. And now today, 2020, we are doing comprehensive genomic profiling. And this is CGP. And again, in 2025, we shall be doing exome, genome, and transcriptome. That means genomics and transcriptomics, RNA sequencing also. And then beyond that, 2025, we'll be doing multi-omics study. That means transcriptomics, genomics, metabolomics, all these will be done in one go. And we can reach we can see the tumor from inside the tumor tissue and tumor microenvironment also, besides seeing the tumor itself. So this is the importance of multi-omic study. Next slide. Now, how do we address, what are the current challenges and to address these challenges? There are no specific laboratory guidelines for testing the genes, for testing methods within the NGS technology or any other platforms. How do we address this challenge? A validated CGP panel must include robust analytical validation, extensive clinical validation, demonstrating the clinical utility and cost effectiveness. That is the first point. Then methodology often includes targeted gene sequencing, all whole exome sequencing of tumor DNA and RNA, which is transcriptome sequencing, which I told earlier. And the protein expression signatures are best approved in clinical setting by IHC, that is immunohistochemical methods, and RT-PCR as compared to other technologies due to its sensitivity and specificity and robustness and well validated in the clinic. Next slide. How CGP helps in different solid cancers. So today we shall be talking about CGP in solid tumors. Next slide. Now this we know, let us talk of lung cancer. We all know the histological classification of lung cancer. We divide them into non-small cell and small cell lung cancer. In non-small cell also we have variants like large cell, like with sarcomatoid variant. We have adenocarcinomas, we have squamous cell carcinomas. So all these are traditional histological features. But now what do we have with CGP coming in? Next slide. Now we have biomarker testing. So in all histological subtypes, we do the molecular testing, including EGFR mutation, ALK, these are all category 1, ROS1, BRAF, NTRK1, 2, 3, MET exon 14 skipping mutation, RET. Testing should be conducted as part of broad molecular profiling. PDL1 testing is category 1. So what do we do now? We do the entire lung panel, or we could in lung cancer, or we could do NGS or CGP. We can do CGP and get all the molecular markers at one go. Even in squamous cell carcinomas, we can go in for molecular testing. Nowadays, we are doing testing for both adeno and squamous non-small cell lung cancer. Next. Now, this is a flow diagram where you will see, it's a complicated slide, but this is the algorithm for molecular testing. And the red dots you will see where CGP is indicated. But nowadays, what we are doing at the onset, if you do the CGP in, like, for example, stage 4 lung cancer comes, then we do the CGP at one go, or we do the lung cancer panel. As I told, if you do once 3 genes, then 4 genes later on, 5 genes later on, instead, we can do CGP at one go. And here are the indications in primary setting and in the secondary setting where metastasis develops. Here we can go in for CGP. Next slide. Now, most important thing here is epithelial mesenchymal transition. How the tumor grows. The epithelial mesenchymal transition is there, and tumor progresses on TKIs, that is tyrosine kinase inhibitors. There is transformation to small cell lung cancer. Now, non-small cell can transform to small cell lung cancer. In EGFR TKIs, we have first generation Geftinib, Erlotinib, Refatinib. Then we have second generation, we have third generation, where 790M is there. We can use osimertinib. We have the data from ADORA trial. And here, if we do CGP, we can go in for MET amplification, we can go in for HER2 amplification and PIK3CA mutation. Now here the important thing is that HER2 amplification we don't only do in breast, we also do in other malignancies, especially lung, GI, we do in these. Why? Because HER2 amplification can occur in any other tumor also. And we have nowadays a very important drug which is coming up, that is trastuzumab deruxtecan, and which is called NHER2 for HER2 amplification in GI malignancies or in lung cancer, and that drug works better. And the only thing is we have to take care of ILD with that drug. Now then we have chemotherapy options where there is no molecular mutations present. We can go in for chemotherapy. If the patient is symptomatic, go in for chemotherapy if there are no molecular options. Next slide. Now, IM power 133 was the first study in unlike non-small cell lung cancer, in small cell lung cancer biology. In small cell lung cancer, we used to use only platinum etoposide combination. That means chemotherapy. Now, first time, this is the first study which has shown that immunotherapy added to chemotherapy gives us the PFS advantage, gives us the OS advantage, when atezolizumab is added to chemotherapy in extensive stage small cell lung cancer. Next slide. Now here you see, if you see the graphs, this is the atezolizumab placebo versus placebo. If you see both, the HR value here also supports that atezo is better than placebo. And if you see lower down on the forest plot, you see all are in favor of atezo. That means the immunotherapy along with chemotherapy is working better. It gives us PFS advantage, it gives us OS advantage. Overall survival is better and the progression-free survival is better if we add immunotherapy to chemotherapy. Next slide. Now, if we see in the early stage vis-a-vis the metastatic stage, here you see the KRAS mutation, EGFR mutation, BRAF, and the other genes. In early stage, other genes form the major component, whereas in advanced stage, other genes form the lower component or less component, and EGFR becomes the major component here. And we have all other gene mutations occurring in early stage and metastatic stage. And here, we have the genomic alterations, which we can tackle them with all the new therapies, targeted therapies, which we have. Next slide. Now, if we see STK11 mutation, again, we see quite often, and STK11 mutation is a poor prognostic marker for immunotherapy in solid tumors. Now, here you see STK11 wild type and STK11, the blue is the STK11 wild type, and the other one, red one, is the STK11 mutation. You can see the widening of the curves. So here 12 months versus 6.3 months. And here you see both in first line and in second line advantage in PFS and OS. Overall survival and progression-free survival. The difference in OS was more pronounced in the second line IO therapy, that is immuno-oncology group, patients with STK11 mutation versus STK wild type. Next slide. Now let us go on to breast cancer and comprehensive genomic profiling, because this is the most common cancer in females worldwide and in India also. Next slide. And if we see, we have subtypes of breast cancer, because all cancers are not one cancer. Nowadays we have heterogeneity of the tissues or heterogeneity of markers, biomarkers. We call them luminal like, luminal A, luminal B. Luminal A is endocrine sensitive because ERPR, the hormone receptors, estrogen receptor and progesterone receptor, both are positive, and HER2 gene is negative. Here, luminal B, where chemotherapy is added, here it could be HER low and ERPR positive. And then we have triple negative breast cancer, in which ERPR and HER are low. Low means they are not present, or they may be very minimal present. We call them triple negative because they are most aggressive of all the cancers, and they offer BRCA testing. Here, as I told earlier, in all triple negatives, we go in for hereditary gene panel germline testing, where we find BRCA markers. And this is the indication for chemotherapy in tumor stage T1B onwards, and anthracycline taxane-based chemotherapy is given, and we add sometimes platinum also. Whereas in HER2 positive, again, let me tell you that in triple negative, we give neoadjuvant chemotherapy and then go in for surgery. And in HER positive also, where HER2 is positive, we go in for neoadjuvant chemo and HER2 targeted therapy. So that means trastuzumab, pertuzumab, as well as taxane-based chemotherapy. We go in for this, and then neoadjuvant chemo. After neoadjuvant chemo and anti-HER2 therapy, then we go in for surgery. Next slide. Now here I would like to explain more that predictive molecular testing or on breast cancers, we have the biomarkers, as I told, ERPR, HER2, these are the biomarkers. Just a minute. So we have ERPR, HER2, these are the biomarkers, and expression, here you see the test detects the expression gene amplification, and here you see the ER positive tumors predictor of response to endocrine therapy. It can be done by IHC, and we have invasive breast cancer where PR is positive on immunohistochemistry. This is predictor of response to endocrine therapy. When HER2 gene amplification is there, we do by in situ hybridization. We have fluorescent in situ hybridization, which we call it FISH, and it is a predictor of response to HER2 targeted therapy such as trastuzumab, pertuzumab, lapatinib, or trastuzumab emtansine. Invasive breast cancer, if we do HER2 protein expression, when we have to see, we do IHC, immunohistochemistry, and early invasive Ki67, it is a protein expression, tumor proliferation and growth, and we see by IHC, and it is a prognostic marker for chemotherapy response. Now, why it is important? We always do Ki67 because Ki67 is a proliferative marker along with ER, PR, and HER. And these are the genes which are important. And here, if you see the cancer type and biomarkers, BRCA1, BRCA2, and we have other genes also, germline mutations. And when do we do in metastatic setting? But now in 2021, we have Olympia trial, which has been presented in ASCO this month. And it showed that in adjuvant setting also, we can use PARP inhibitors in adjuvant setting also after we have given chemotherapy in breast cancer. Next slide. Next slide, please. Now you see, make it bigger. Bigger. Okay. Now, as we see, stage 4 metastatic breast cancer, NCCN guidelines also have come up with the guidelines of doing comprehensive genomic and somatic profiling in the advanced stage of breast cancer. That means in stage 4 breast cancer. Next slide, please. Now, mechanism of hormone therapy resistance in breast cancer. These are the promising hormone therapy in breast cancer, which we use anti-estrogens. Anti-estrogens, we are using estrogen like, for example, tamoxifen we are using, and we have the estrogen alternative pathway, independent activation can be done on estrogen receptor elements are there. And if we see the androgen receptor or the aromatase inhibitors, which convert androgens to estrogens, here also we have alternative pathway, and we have proliferation of breast cancer cells. Again, IGFR, insulin growth factor receptor may be there. So we have hormone resistant pathways which come into being because once we are using hormone therapy in hormone positive breast cancer, we have mechanism of resistance, which I shall be showing you later, which are the mutations present. Next slide. Now you see one form of mutation is ESR1 mutation, where we might have wild type and splice variants, and they harbor amplification of ESR1. There may be point mutations in the kinase domain, and there may be other mutations or fusions in the ESR1. It may be ESR fusion, and in ESR mutations, we use degraders, ESR degraders like fulvestrant, and we don't use aromatase inhibitors as hormone therapy. Next slide. Now you see in TNBC, triple negative breast cancer, this is very important because most patients, psychologically they are down because they hear from other patients that triple negative is most aggressive, and the patient feels that she is going to die with triple negative breast cancer. It is not true. We have high proliferation triple negative, low proliferation type, and TNBC with increased TILs. TILs is tumor infiltrating lymphocytes, and we have androgen receptor expression, and we have low expression type. And again, there are various subtypes, basal-like, claudin-low, and non-basal-like. And we have metaplastic type where c-KIT inhibitors work. In metaplastic, we have overexpression of c-KIT. And we have basal-like 1, basal-like 2, or immunomodulatory, or mesenchymal type, or mesenchymal stem cell type, or luminal androgen type. Again, we have basal-like, as I told, immunosuppressed, and basal-like immune activated. So both in basal-like also we have two subtypes, and mesenchymal, then luminal androgen receptor-like. Now here also we have the BRCA1, BRCA2 germline mutations and somatic mutations in BRCA1, 2, and PALB2 genomic test, and we can do genomic scans for TNBC with HRD, homologous recombination deficiency, and we do PD-L1 expression also nowadays because immunotherapy also in PD-L1 positive. It may be, if immune infiltrate is there, we can use immunotherapy in these cases. And high-grade tumors, we always use chemotherapy with anthracycline and taxanes. Next slide. Now, TNBC, as I told, PD-L1 testing is done in all the cases. We have the data from atezolizumab plus immunotherapy plus chemotherapy, and if PD-L1 is positive, and pembrolizumab also another immunotherapy agent with chemotherapy has been used. And then we do next generation sequencing in which we may have, BRCA1 or 2 mutations, HRD, where we use PARP inhibitors or platinum therapy, and we have anti-RK gene fusions where we use entrectinib and larotrectinib. We have MSI high or TMB high where we use pembrolizumab, another immunotherapeutic agent, and where we have PI3K AKT pathway, and we have AKT inhibitors. Now, ipatasertib is AKT inhibitor, and then FGFR, we have FGFR inhibitors also. And as I told earlier, trastuzumab deruxtecan, this is a new drug which has drug antibody drug conjugate, which has come for HER2 positive breast cancers also, and HER2 positive non-breast cancers also. And these, the other vaccines and other antibody drug conjugates are in clinical trials. Next slide, please. Now, if we see that prognosis of germline BRCA mutation status in TNBC and non-TNBC. So germline BRCA mutated are TNBC diagnosed, and TNBC group germline BRCA carriers had prolonged DFS. Here, if you see properly, you can see that in TNBC and non-TNBC, there is a difference in both. You see more DFS and OS difference. In non-TNBC, the BRCA1 and BRCA2 mutations did not have any impact on survival. But in TNBC group, BRCA carriers had prolonged DFS, hazard ratio of 0.5. Next slide. Next slide, please. Now I would like to highlight that this is a new news release recently that antibiotic novobiocin found to kill tumor cells with DNA repair glitch. This antibiotic was found in 1950, and now it has been shown to kill the tumor cells with DNA repair glitch. And how does it kill? That it has polymerase theta inhibitor action, Pol-Q inhibitor, and Pol-Q inhibitor can kill HR deficient cells, homologous recombination deficient cells. So this is a new thing which has appeared in Nature about 1 week back. Next slide. Now, pancreatic adenocarcinoma and other carcinomas also, we can do BRCA mutations, we can do hereditary gene panel and somatic panel, NGS also, and we have the whole gamut of, PARP inhibitors which we can use for pancreas, prostate, and ovarian cancers. They form important when there is mutation in the hereditary cancer genes. And there may be mutation in NGS also when we do in other genes, and we can treat accordingly. Next slide, please. Now, what are the tumor agnostic markers? That means they are the markers and comprehensive genomic profiling. They are tumor agnostic markers, means they can be in any tumors. And what are those markers? Next slide, we would like to see. They are anti-RK1, anti-RK2, and anti-RK3. And here we see they are present in gliomas, colorectal carcinoma, cervical carcinoma, lung adenocarcinoma. And all these tumors shown here are in anti-RK1, 2, and 3 are present, and larotrectinib and entrectinib are the approved drugs in pan cancers with anti-RK fusion. That means in any cancer where we have anti-RK fusion, we can use larotrectinib and entrectinib. So this is called tissue agnostic approach. Next slide. Another tumor agnostic biomarker is RET fusion. RET fusion constitutes 2.5 to 73% of sporadic papillary thyroid cancers, and 1 to 3% of non-small cell lung cancers. And several multi-kinase inhibitors are approved that include sunitinib, sorafenib, vendetinib, cabozantinib, regorafenib, ponatinib, lenvatinib, and alectinib. Now, most important are the recent inclusions of pralsetinib and selpercatinib have shown good efficacy and low incidence of serious adverse events. So these are two very important RET inhibitors, recent onset, recently approved by US FDA, and have shown good efficacy and low incidence of adverse events. Next slide. Now, genomic signatures and CGP relationship between TNB high, MSI high, and PDL1 high across all cancer types. If we see, we have PDL1, we have tumor mutational burden high, MSI high, and detection of TNB and MSI by whole exome sequencing proved to be gold standards, and CGP based on whole exome sequencing provide optimal information not only on TNB MSI, but also covers known and novel fusions like NTRK, ROS1, ALK, and FGFR, which partner with several other genes. Now, most important is whole exome sequencing approach also helps in development of new tumor agnostic signatures, such as neoantigens, epitopes, and mutational signature landscape. So that means if we do whole exome sequencing, we can know the new neoantigen epitopes and we can know the new mutational signature landscape. So this is very important for this. And all these three biomarkers are important for immunotherapy. Next slide. Now, CGP is a patient-centric test, evidence-based approach. Is it a patient-centric test or not? Next. Now, if we see the association of biomarker-based strategies with response rates and progression-free survival in refractory malignant neoplasms. All the tumors which are refractory, and if we see here you see on the left side where number of patients, we have seen meta-analysis from 346 phase 1 clinical studies. Inclusion criteria was biomarker-based selection strategy. Outcome was improved response rate, median of 30.6 versus 4.9%, and progression-free survival was 5.7 months versus 2.95 months. This was median survival. So progression-free survival was better where the biomarkers were there. And here you see on this side, the progression-free survival is better in biomarker-driven strategies than with conventional strategies. Next. Now here is the non-personalized approach and personalized. The red dots comprise of non-personalized and the blue dots comprise of personalized approach. And here you see the response rate is over 60% in personalized approach, and it is about 5% in the non-personalized approach. So personalized approach is always better than non-personalized approach. And we have also seen biomarker-driven gives us progression-free survival advantage. And we know, for example, I will give you an example of EGFR mutation, simple example in lung cancer, where exon 19 is deletion and we give, or where T790M is present, and if we give osimertinib, the patient responds very well. Earlier, what we used to see in stage 4 lung cancer, hardly it was 6 months to 1 year survival advantage. But now with modern targeted therapies and biomarker-driven therapies, we can go up to years. And I tell you, it is 5 years also. So it has made a lot of difference in our treatment strategies also. Next slide. Now there was a retrospective analysis of precision medicine outcome in patients with advanced cancer It revealed improved progression-free survival, as I told earlier, without increased healthcare costs. So this was a publication, retrospective analysis. Next slide, which I shall show you. Here you see the progression-free survival, 22.9 weeks vis-a-vis 12 weeks with both the blue lines is the progression-free standard treatment, and the yellow line is the precision medicine treatment. So precision medicine treatment always scores better than the non-personalized treatment. Next slide. So these are some case studies which I wanted to share with you, which I have treated at our center, and I have treated using molecular basis. I have treated myself. Next slide. I shall highlight a 75-year-old elderly male diagnostic of metastatic CRPC after getting all the treatments done, chemotherapy, hormone therapy. Then I got foundation one done, that is CGP done, and I found that MSI was high, TMB was 53 mutations per megabase, and BRCA2 mutations were present. And PDL1 was 100%, mind you. And in that case, I started on pembrolizumab because PDL1 was 100%, MSI was high, so pembrolizumab plus olaparib. And HON1 was continued as a hormonal treatment. And here you see in this, after doing this, the treatment responses were dramatic. Dramatic in the sense the patient was on wheelchair and now the patient is moving around and he's 70 plus 75-year-old and he's moving around. He says, I've become younger by 10 years, more than 10 years. So this is the hallmark of molecular medicine or CGP. Next slide. Case 2 was TNBC with germline HRR mutation. And here also it was BRIP1 mutation, exon 17 mutation. And there was foundation 1 showed RAD21 amplification and PDL1 negative and MSI stable. Tumor mutational burden was low, 3 mutations per megabase, and started on paclitaxel and carboplatin, which is chemotherapy, and evaluation done at 12 weeks showed no FDG avidity in bone marrow. Bone marrow was absolutely cleared in 12 weeks. And then planned for carboplatin plus olaparib. Platinum sensitizes olaparib sensitivity. So that is why PARP inhibitors were used in BRIP1 positive somatic as well as germline. And here you see the response, excellent response. Next. 70-year-old elderly male, another case, diagnosed case of recurrent metastatic adenocarcinoma colon. Now, this case is very important for me and to show to all of you that, with metastatic disease, after, sorry, now patient received conventional treatment and then I did KRAS. There was exon 2 mutation. Then MSI was high. And what I did, MSI high, added pembrolizumab, KRAS mutation 2, added bevacizumab, and capecitabine I gave to make the tumor hot. And we always call it make the tumor hot means make the tumor immunogenic. And this is the PET-CT, and this is only 1 year. Let me tell you, the patient is living with metastatic disease, stable disease for 2 years and more than 2 years. And this is really a miracle. He says, you have created a miracle here. And I'm going to publish this case as an excellent case where he was going for surgery of the lung, and I couldn't show the earlier slides in 2019 where the lung was full of disease and the lung is free of disease. The biopsy is negative. So excellent response. Next slide. So what is the take-home message and lessons and the way forward? CGP is a genomically matched treatment option as per standard of care as a coexisting category and for clinical trials and rescue strategy for those who have progressed. So that means for clinical trials, it is a coexisting category and rescue strategy for those who have progressed. Don't lose your heart if a patient has progressed. You must go in for CGP wherever possible and whichever drugs are available for the particular guidelines, we can always go in for it. There is always explosion of knowledge of biomarkers, thereby increasing the efficacy of CGP in precision oncology. And there is a lot more to learn and contribute to this field of medicine. And I always say that after teaching in AIMS for more than 30 years, I always feel I am still a student and I remain a student forever. Thank you very much.
Thank you so much, sir, for this exciting lecture. Uh, so we have 3 questions here. How gene expression profiling helps in identification of biomarkers in drug discovery?
This gene expression signatures can help us once we are doing these signatures, supposing breast cancer. You know, in one of the cases, I will highlight one of the cases where I did the gene expression signature and that showed PI3 kinase mutation. In that case, you know, the patient was already on hormone therapy, patient was hormone positive, and once PI3 kinase mutation is there, patient becomes resistant to hormones and starts progressing. So then we have PI3 kinase inhibitor called alpelisib, and we started the patient on alpelisib, and there was a fulvestrant is the partner, the endocrine partner, and the patient responded very well to that treatment. And another patient I would like to share where I did the CGP, where I found from foundation one again, and I found EI3 kinase positive, that means mutation positive, and P10 loss. That means P10 mutation was also present. Here, PI3 kinase inhibitor will not work. So what will work? The downstream mTOR pathway will work. That means simple everolimus tablet will work along with hormone therapy. So this is how it works.
Okay. So there's another question, sir.
Yes.
There are many targeted panels like you know, 300 gene, 400 genes, 600 genes, and several panels. And there is also whole exome sequencing as part of CGP. So do you have any specific recommendations or choice between the two, or how do you assess them?
Yes. Because as I showed earlier, that once you do CGP, you can get the entire scenario in front of you because scenario means that you can get the entire genomic profile, you can get TNB, you can get the MSI, you can get the mutational burden, and you can also get the mutations in various genes, and you can get the therapy alternatives also. So once you detect the mutations, you can always decide upon the therapy which to use. Now, for example, in pancreas cancer, you know, we always know KRAS-driven cancer. Nowadays, KRAS G12C mutation has come up, and we have two drugs approved by US FDA. KRAS G12C, we have sotorasib, one drug, oral drug, and we have adagrasib. These are the two drugs which are approved for G12C KRAS mutation. So once mutation is there, we have the approved drugs which are approved by US FDA. And of course, NCCN guidelines will come later. You know, you should not wait everything as per NCCN guidelines. Because as soon as FDA approves, it approves after certain, discretion. It does not approve at random. So once it is approved for G12C, you can go in for clinical trials, or you can get those drugs. Those drugs are not available in India, but you can always ask the patient to go enroll for clinical trials.
So then there's another question.
Yes.
Do you think the TMB would be different for Asians as compared to Caucasians?
Yes, this is a very good question because let me take you back to EGFR. You know, I'm going back to EGFR days. I'll come to TMB later. EGFR days, earlier people said, you know, uh, EGFR is positive in 12 to 20% of the cases. I said, don't believe this data. This is US data. EGFR in Asians is much more. And once we did our study in AIMS, I did my own study, I found more than 20% had EGFR positive, 20 to 30%. So similarly, TMB could be different. We don't have the enough data for TMB, but TMB is also different for different tumors. For example, in lung cancer, we always say TMB more than 10 megabase per megabase, mutations per megabase. So more than 10, we call it high TMB for lung cancer. For breast cancer, it may be something different. For another melanoma, it may be different. So for each tumor, TMB is different, and that they are trying to find out the FMI, the Foundation Medicine of India, the FMI is also trying to find out, the Foundation Medicine is trying to find out what should be the adequate TMB for each tumor type. So that has not been validated as yet.
Then there is another question. Uh, in precision medicine approach in oncology, when we do the response assessment criteria, RESIST or IWG, should we include all the molecular level parameters to do the assessment of response?
Yes, assessment of response, we have the RESIST criteria. We have uh, the modified RESIST criteria also. There they have, in some of the cases, they have not mentioned about molecular responses. We can always uh, include molecular responses and say it separately. Sometimes what happens, they write stable disease according to RESIST criteria. Now, according to molecular criteria, it may be a response. So we can always say RESIST criteria says stable disease, and the molecular response says there is a molecular response in a way that, because all molecular responses are not included in RESIST criteria.
Mm.
So we have to tell them separate.
Okay. Then another interesting question.
Yes.
In clinical practice, do you repeat CGP in patients when they progress?
Yes. This is very important question, and I have done in 2 cases in this month. You know, so
Okay.
because in the case of CA pancreas,
Uh-huh.
first we did foundation one, and we got certain KRAS mutations present, and we started the therapy, FOLFIRINOX chemotherapy first line. I started. The patient had metastatic disease, metastatic CA pancreas, and let me tell you, patient is living after 1 year without disease. And so once she progressed on this, she had bilateral lobes, liver lobes involved. And then once she progressed, I took the biopsy from liver now this time and sent it for again foundation one to know the resistant mechanism. So if you can do again, I know it is expensive affair, that patient could afford it. So I got it done again. In two patients, I've got it done again. And in one patient, I've got the liquid biopsy done again in lung cancer. So you can do it again to know the resistant mechanism. That means which genes are responsible for resistant pathway. There may be KRAS, some other G12D type. You know, that patient has KRAS G12D. It might change to G12C, where we have drug called sotorasib, as I told you. So we can get some other information also. That is very important to do it again.
So this is a couple of people have asked this question. Um, in which solid cancer types do you recommend both HRR and TMB, or TMB alone? Do you have any specific cancer
You,
types where you do that?
you don't do TNB alone. You once you are doing CGP, it always
Solid.
covers TNB. TNB and MSI, it always covers. You know, once we are sending, for example, we are sending for foundation one, they always cover TNB and MSI. And there is no separate TNB alone. Of course, in other tumors, in germline testing, we do in all TNBCs, you know, triple negative breast cancers, we'll do in prostate cancers, we do in pancreatic cancers, and we do in ovarian cancers. These four cancers you must do germline testing. BRCA1, BRCA2, PALB2, DRIP1, all the germline testing should be done in all these four tumors. Triple negative breast, ovarian, prostate, and pancreas.
So another question, we have seen a lot of experience of application of CGP in solid tumors.
Yes,
Do you think CGP will be advantageous for hematological malignancies also?
very advantageous because nowadays in multiple myeloma, you must have heard that immunotherapy is coming in, you know, in multiple myeloma. Now we will get more targeted therapies. Midostaurin has been given in AML. So what I am trying to say in hematological malignancies, you will not find after 3 to 4 years or 5 years anybody going in for bone marrow transplant. So we might have certain other drugs with CGP. So it would be very useful in hematological malignancy.
So do you recommend STK11 mutation for
Yes,
all PDL1 positive cases before starting immunotherapy?
yes. STK11 mutation should be tested. That is why we go in for CGP. And as STK11 mutation, as I showed you, it has poor response to immunotherapy. So if STK mutation is present, you go in for mTOR inhibitors. For example, everolimus. So everolimus works better for STK11 mutation positive cases. So don't go in for immunotherapy.
Then this is an overlapping question. So they are asking that, have you seen changing the CGP results during in recurrent tumors all the time?
Yes,
I mean, when you keep repeating.
I've seen changing results. First time when we do CGP, it has X, suppose X number of genes. Once we do next time, we find different set of genes. I will give you one example. One of our patients, lung cancer patients, had ROS1 fusion, right?
At baseline.
We put the patient on crizotinib.
Mhm.
2.5 years patient was fine. After 2.5 years, the patient progressed. And then we did CGP again. There was no ROS1. So ROS1 finished with crizotinib. So then the patient had, you know, other PDL1 positive. The patient had other mutations positive. So we put the patient on atizo or immunotherapy and chemotherapy. The patient is still living because third time we did CGP. in that patient. And third time it showed CDK4 amplification. So I put the patient on CDK4 inhibitors like abemaciclib. So what I am doing, completely molecular guided therapy, and patient is responding.
So there's another question, sir. High-grade serous ovarian cancer,
Yes,
when there is negative BRCA and HRD,
yes,
can we use olaparib as
no,
maintenance?
no. Olaparib as maintenance we are using mostly for the BRCA positive or hereditary gene positive cases. In those cases, we are using BRCA, the PARP inhibitors, because they are generally resistant to PARP inhibitors, mostly. There we use other drugs as maintenance therapy. For example, tazobactam we are using as maintenance therapy, or bevacizumab some people were using, but recent data in ASCO has shown that overuse of bevacizumab has not produced good results. So let me tell you that in this ASCO, they have clearly pointed out that if it is BRCA positive or if any of the hereditary genes are positive, only then you use PARP inhibitors. In PARP inhibitors, resistance can develop anytime. And then we have, as I showed, novobiocin as antibiotic or POLQ inhibitors, polymerase theta inhibitors, which are coming up for PARP resistant tumors um, against HRD cells, hormone,
When
uh, this recombination deficiency.
then what percentage of people have TMB high when there is a PDL1 negative? What is your experience like?
TMB high,
Yes.
that is in small percentages, so 10 to 20,
Okay. Less than 5% or 10%, sir?
10%, less than
10%. Okay. So yes, yes,
10. Any other questions?
pretty much we have covered most of the questions.
Yes.
Next options for patient.
Any other
Yes,
questions?
sir. Uh, yes, sir. Almost most of some of them were repetitive questions. So I
Okay.
have covered pretty much uh, all the queries.
Okay.
So here there's a you already mentioned in your presentation, so they won't probably reconfirmation. How often do we get mutations in squamous cell carcinoma when we do an upfront CGP panel?
Yeah. Very good question.
Mm,
In squamous cell, we get less often
mm,
mutation. Mhm.
mm.
In adenocarcinoma, we get more mutations.
Okay. Okay, sir. Yes, sir. In the interest of time, I think we will wrap it up now. Thank you very much once again, sir, for
Okay.
this exciting lecture. And
Yes, some group
we,
because I was trying to move the marker
uh,
and the whole thing, sprang.
yes, sir. So we also thank all the participants for taking their time in listening to this lecture from Professor Julka. Uh, we thank you all once again and have a good evening and happy weekend.
Thank you very
Thank
much.
you, sir.